Hello everyone, I'm Mirela-Diana Ilie, an EYRC board member, and I'm delighted to be interviewing Professor Niki Karavitaki. Although she doesn't really need an introduction, I'll mention that she conducts her clinical and research activities in Birmingham, UK. She is a world-renowned pituitary expert and a mentor and role model to many of us. Professor Karavitaki, dear Niki, thank you for having accepted the invitation.
Thank you very much, Mirela. Thank you for inviting me. Thank you for your kind words. And it's not just a pleasure, but a great honor for me to give this interview to you and, of course, to the European Neuroendocrine Association. So thank you again.
To be honest, we have been planning this interview for a while. Initially, I had a couple of topics in mind, but Professor Karavitaki has finalized some other equally interesting projects in the meantime. Niki, I'd like to take this opportunity to ask you about several of these topics. Is that okay?
Yes, absolutely fine. Thanks.
Great. First, let's talk about opioid-induced endocrinopathies. Despite opioids being frequently used, opioid-induced endocrinopathies remain underdiagnosed and not optimally managed. As an international expert on this topic, what do you think endocrinologists should keep in mind?
Yes, thank you for this question. So there is no doubt that there is a global problem with the use and the misuse of opioids. And in many areas around the world, this problem is still growing. And actually, this is the reason the Endocrine Society was keen to develop a scientific statement which will alert the endocrine clinicians, but also other experts, on the hormonal disruptions that these agents can cause. So if we focus on the hypothalamo-pituitary system, what we can start with is that opioids inhibit the hypothalamo-pituitary gonadal system, and they can cause hypogonadism. They may also cause hyperprolactinemia with the known clinical consequences of this finding. And they also inhibit the hypothalamo-pituitary adrenal axis. And we have many reports of low morning cortisol or compromised response of the cortisol on dynamic testing. The other pituitary hormonal axes have been less well studied, but the ones I mentioned, I think, are the most clinically important. So the endocrinologist, but also other healthcare professionals who look after patients on opioids, need to be aware of these effects, inquire about relevant clinical manifestations, and if need be, test and manage accordingly.
Thank you. In the video description, we will include links to the relevant bibliography, including Professor Karavitaki's review in the Lancet Diabetes and Endocrinology Journal and the expert opinion she co-signed. And speaking about Lancet Diabetes and Endocrinology, I remember reading with great interest your paper on the risk of second-grade tumor after radiotherapy for pituitary adenoma or craniopharyngioma. Could you tell us a little about this multi-center study? What would you say is the main take-home message?
Right. Well, I have to say that this is a question I had in mind for many, many years. And we do know that there are data which support the view that radiotherapy for pituitary tumors is associated with risk of second brain tumor. And this is not a surprise, knowing how radiotherapy works. However, the methodology that was used for the quantification of this risk, I think it was weak, mainly because as controls, they used many studies, used the people, used the general population. So they extracted data from there, and we know that the general population does not have the imaging surveillance that a patient with a pituitary tumor has. And another point was that this event is rare, and it takes a long time until a second brain tumor becomes apparent. So what we did is we joined forces, some endocrine departments in the UK, and also we had collaborators in Italy, and we collected data from more than 3,500 patients with pituitary adenoma or craniopharyngioma. The patients, some of them had received radiotherapy, some others had not. This was conformal radiotherapy or intensity modulated radiotherapy. And we found that the rate ratio for second brain tumors after comparing the two groups was 2, which is much lower than what previous studies had suggested. We think that this is an important finding because it informs the clinical practice. It guides us on how to counsel patients when we talk to them about pituitary radiotherapy, and addresses, I think, a serious concern about a late toxicity of radiotherapy, which, in my opinion, had not been very well studied in the past. So this is about this study, which was a beautiful collaboration of many, many wonderful colleagues.
It really was, and it was really reassuring. So really, thank you for having performed this study. And when it comes to pituitary adenomas, I found very useful your paper on the natural history of non-functioning pituitary microadenomas. More recently, you published another paper, this time on conservatively managed non-functioning pituitary macroadenomas, which is equally useful. And it was like making a full circle, which was really nice. What do you think we should bear in mind regarding the natural history of non-operated micro and macro non-functioning pituitary adenomas?
Thank you for this question. So this was another collaborative study, this time only from the UK NFPA consortium we have set up with 23 departments taking part. And as you mentioned, they were published in the European Journal of Endocrinology. So if we focus only on the micro NFPAs, presumed, of course, because for nearly all of them, we don't have histological proof. If we focus on this, and essentially majority of them, or a lot of them, were incidentally found, what we identified is that the cumulative probability of enlargement remains low during the first 3 years of follow-up. It was around 8%, and those which grew, essentially they don't have any clinical consequences. And this told us that we don't need to rush and rescan the patients with a presumed micro NFPA in 1 year, and there are some guidelines which used to suggest that. Our data suggested that the first scan could be easily done in the first 3 years, provided, of course, that the clinical picture of the patient doesn't change. And this conclusion was also adopted in the recommendation of the Pituitary Society consensus guideline, recently published in the Nature Reviews Endocrinology, in which it is suggested that the first scan for micro NFPAs, it is better to be done in 3 years rather than earlier. And by this way, of course, we don't waste resources. So I think that's the main message for micro NFPAs. If we go to macro NFPAs, so we had a cohort of a little bit less than 1,000 tumors, and we looked at their natural history, we looked at their outcomes. And again, focusing on the tumors which were not in contact with the optic chiasm, we found that the probability of enlargement in the first year is low. And not only that, but those tumors which showed enlargement, the clinical consequences, and I'm focusing on vision, were rare. So the enlargement within the first year was around 6%, the cumulative probability of enlargement. And we know that guidelines suggested that for presumed macros, macro NFPAs, we do a scan in 1 year. But again, this data showed that, again, we don't need to rush. We can do it in 1 year, specifically for tumors which are far from the chiasm. And again, the Pituitary Society suggested that tumors which have a distance more than 5 millimeters from the optic chiasm, they can be scanned within a year rather than 6 months. So this was one finding. Another interesting finding is that we saw that there were tumors which enlarged. If they were left, a significant number of them continuing enlarging. Some tumors shrunk, and the behavior of the tumors is that some shrunk, or they remain stable, or continue to shrink, or they enlarged, suggesting a variable behavior of the presumed non-functioning pituitary adenomas. And another point which we found interesting is that the pituitary function for tumors which remain radiologically stable in the very, very vast majority also did not change. And I think this is something we need to take into account when we follow up these patients. So many more conclusions. Obviously, we don't have the time to go through this, but I focused on what I think would be the most important.
Thank you, and congratulations on this tremendous work that truly informs clinical practice. And now that the EndoCompass Research Roadmap project has just been published, and given that you're one of the leaders of the pituitary and neuroendocrine tumor endocrinology part, could you tell us what would you consider to be 3 top priorities in pituitary research right now?
Yeah, so it was a great project from the European Society of Endocrinology, and it represents the brainstorming of many ECE members. It's difficult to focus on the 3 most important, but obviously, since you're asking me, I will do without minimizing the value of the other priorities. I think one important priority is to understand the mechanisms of regrowth of the pituitary tumors after the primary treatment, usually surgery, or the mechanisms which relate with partial response or non-response to medical treatment. We are talking here mainly on functioning pituitary tumors. And hopefully this could allow us develop new, more effective medical treatments. A second, and I think it's very, very important, and I'm sure you are also sensitive to that, is to identify markers of early prediction of aggressive pituitary tumor behavior. This is something that needs to be investigated more thoroughly. And although this would represent a small number of patients, still we know that in clinical practice we quite often we don't have much to offer to these patients. And another priority for me is that it would be useful if we developed European databases for research for rare, but also for ultra rare pituitary pathologies, because only through this type of collaborations we will be able to have meaningful data. So these are probably 3 I could mention. If I gave another interview, maybe you asked me for 3, maybe I could give a different, but at the moment, this is what I would focus on.
Yes, I'm sure it's the case. Thank you, Niki. I'd now like to switch to the mentoring side of this interview. The first question that comes to my mind is, how do you choose the projects you work on?
Yeah, I am a clinician, so I have to say that most of the ideas or questions come when I see a patient or a group of patients. So clinical practice allows me to identify a gap in knowledge or in the care of the patient or in the clinical pathway that patients follow. And then this, I would say, triggers the fire, the curiosity, the effort to try and answer this question. That's the main way. Having said that, of course, conversations, discussions with colleagues, with fellows, with trainees also contribute, or ideas that we get from attendance from congresses, meetings also play a role. But mainly, the clinical room is the one that gives me the idea for projects.
Thank you. Another thing I'm keen to know is how we manage to stay on top of everything. And by everything, I mean not only the clinical and research work, but also your very active involvement in numerous scientific societies, as well as patient education and advocacy. And what is one thing you feel you do well balancing your various roles and responsibilities?
Okay, well, I think that as medics and as academics, our task is not only to work for and promote the care of our patients or our research data, but also to be good academic citizens at a local and at a national level. And this is where my involvement with the other aspects that you mentioned comes from. Now, I think one of the things that probably I do well in balancing these roles is keeping my enthusiasm and fire to try and contribute to the wider picture, to, if I may say, to the greater good. And this gives me a positive feedback to balance the roles and make things work. So probably it's something intrinsic, but yes, it's keeping the fire and the love and the enthusiasm for this.
Yes, great answer. But since there always room for improvement, what is one thing you'd most like to change about how you balance your various roles?
Right. Okay, that's a difficult question, but I would uh, I would like to be able to say no to some distractions or less important jobs that appear during our professional life. But again, this is part of our pathway. I don't know if this can change, but if there was a small thing I would like to change, I would like this to be this one.
I remember you saying at an INEA meeting that when you do something such as writing or reviewing a manuscript, you focus on doing a great job the first time around so that you don't have to spend time twice doing the same thing. I found that really useful, and I've even adopted it for myself. Is there any other tactic you use to be efficient?
Okay. First of all, it's very nice to hear that you have also found this useful. And I have to say that this advice was given to me when I was in high school, when I was 14 years old, by one of my teachers. And since then, I've been trying to follow this. Now, having said that, I have to emphasize that everyone has their own way of working, and everyone has its own recipe. So what I'm going to say or what I follow doesn't mean that it is the gold standard. But another piece of advice that I'm trying to follow, strategy, is very good time management, as much, of course, as we can, and try and have good discipline, which is not always achieved, but it's something that we need to try and chase up and implement in our professional life, because that's the only way, not only we can be efficient and productive, but sometimes that's the only way we can survive.
That's true. To end on a high note, I have one last question. If you had to give one piece of career advice to early career neuroendocrinologists who are looking to have a combined clinical and research career, what would it be?
Okay. The advice would be find a specific area in the field of neuroendocrinology and be passionate about this and serve it with scientific rigor and high standards, without, of course, forgetting that we have to develop also as endocrine clinicians. We will look after patients with all sorts of pathologies. I think this passion, combined with a good mentorship and good collaborators, will bring us the dedication, the perseverance, the mental and emotional rigor to keep going despite failures, despite disappointments, despite challenges. And we have to remember that clinical academics have this enormous privilege of being able to do meaningful research and at the same time to have the sense of fulfillment which is offered by the humanitarian principles of medicine. And this is a great blessing.
It is. Thank you so much, Niki. It was a real pleasure and honor to interview you today.
Thank you very much, Mirela. Thank you for giving me this opportunity. And yes, I hope we meet again live in a meeting. Thank you.